I've been asked to talk with you about providers and quality. My title is actually the Medical Director for Patient Safety and Risk Management, and we have a separate Medical Director for Quality, but I'll try and make a connection so that I think that whether you talk about quality, patient safety, or risk management, they're really all part of the whole. So you all have the objectives for the session today. So first we'll sort of talk about how long we've been fighting this battle for quality in healthcare. We'll talk about whether we really got our money's worth when we spent $2.6 trillion on healthcare in 2012. And we're going to talk about two groundbreaking organizations, the Institute of Medicine and the Institute for Healthcare Improvement, and see how their definitions of quality compared to what we do on a regular basis. And then we're going to also talk about the relationship between quality, as I said, patient safety, patient experience, which obviously you've heard about because you have the Consumer Report, MHQP report on the table, and we'll talk about peer review and systems engineering as well. So as Phil alluded to, Atrius Health is a very large organization. It's actually a nonprofit group of medical groups. There are 6 medical groups which are listed here. The largest is Harvard Vanguard Medical Associates. We also added a VNA Care Network and Hospice as a partner in October of 2012. We actually have 50 locations throughout eastern and central Massachusetts. We have about 1 million adult and pediatric patients. We had almost 4 million outpatient visits in 2012, and we have almost 1,100 physicians and then another almost 1,500 other healthcare specialties at Atrius Healthcare. So it really is a large organization. I won't posit whether we're the most powerful physician organization in Massachusetts. You will have the opportunity actually to speak with the CEO for Atrius Health tomorrow. He's going to be talking about the ACO. So this is the Institute of Medicine definition of quality. So the degree to which health services for individuals and populations, and I think that's very important that this talks about not only individuals, but the health of populations as well. And the other thing that I think is important about this definition is the last portion, which says consistent with current professional knowledge. I graduated from medical school a number of decades ago. And my husband, who is also a physician, who is the Dean of Educational Affairs at Tufts Medical School, recently delivered a lecture in which he compared care for the heart attack patient between 1980 and today. In 1980, we actually hospitalized patients for about 2 weeks. You don't get to stay in the hospital for 2 weeks anymore unless you're really critically ill. There were no stents available. Nobody got beta blockers when they were discharged from the hospital. And compare that to how we take care of patients who are having myocardial infarctions today. We've really changed our professional knowledge, and this definition of healthcare quality has to change with that knowledge base. So a little bit about quality improvement in healthcare. I know you guys all have the slides, so you can read who this gentleman is, but I like to say Dr. Semmelweis was important because he was the first person, he was actually an OBGYN, which I'm very proud of, and he was the first person to introduce hand washing. We've really conquered hand washing, haven't we? The next person is Florence Nightingale. And Florence was important because she was one of the first healthcare people who talked about the impact of the environment on how healthy patients can be. So she actually looked at the healthcare of soldiers in the Crimean War. And I don't know if any of you have done any historical reading, but it is really frightening to read a historical book about medicine. I recently read a book by the name of My Name is Mary Sutton. This was a woman who trained as a surgeon during the Civil War. So if you really want something to keep you up at night, you can read that. So this was actually a huge landmark study about medical errors in medicine. And I was practicing when this came out, and I remember thinking to myself, well, there's no way that we actually are responsible for up to 98,000 patient deaths a year as a result of medical errors in hospitals. And that's the important thing to keep in mind. This is in hospitals. We're not even talking about ambulatory medicine. And they cost us a lot of money. And what are we going to do about this? I think the first thing was we needed new leaders. I chose to get into quality and patient care. We also needed to start to actually learn from our errors. So, you know, when the Institute of Medicine report was first published, we really didn't talk about our errors in medicine. And now, actually, in Massachusetts, you're required to disclose your errors to patients. So we really need to start learning from our errors, first by reporting them, and then by learning from them. We need to set new performance standards. This was all in 1999. And we needed to look at patient safety as the first step in the process. So 2 years later, we had the publication of Crossing the Quality Chasm. This basically said in one easy lesson, we need care that is safe, timely, effective, efficient, equitable, and patient-centered. Trying harder was not going to work anymore. This is, as I like to say, a very steep mountain to climb. This is not Mount Monadnock. It's more like Mount Everest. And I would say that we are maybe halfway up the mountain in the best of situations. So what about quality in the ambulatory setting? I've spent the last 5 years of my career working solely in the ambulatory setting, and there is really not nearly as much information that's known about quality in the ambulatory setting, or even patient errors in the ambulatory setting. And actually, a few studies have been done. This was a study that was published by Elizabeth McGlynn in the New England Journal of Medicine in 2003. And she showed that only 55% of patients in the United States are actually getting the care that they're supposed to have based on what we know is the right thing to do. Another report from the Institute of Medicine in 2003 said that most of the patients with chronic diseases don't get the care that they're supposed to get. So not doing all that well in terms of the quality of care in the ambulatory setting. Here are some sobering statistics. These are actually culled from a publication called Health Affairs. I don't know if any of you are familiar with that, but they had a quality edition in April of 2011. And some of the studies that were published there had some really sobering findings. The first study by Clausen was a study looking at the IHI's global trigger tool, reviewing hospitalizations, and they actually found that up to 1/3 of patients who are in a hospital have a medical error or an adverse event at some point during their hospitalization. Now, the really scary part from a patient safety perspective is that the normal way that we find out about errors, which is through voluntary reporting, that missed 90% of these errors. So the systems we have in place right now are not the best systems for figuring out where we need to concentrate. Another study showed that these have up to almost $18 billion in cost in terms of the measurable errors, and then the estimated social cost is even higher. So why is it so hard to take care of patients in 2013? I think one of the things that is really sobering is when I was at my last job at North Shore Physicians Group, I dealt with primarily primary care patients or primary care providers. It takes a primary care provider with an average patient panel of 2,500 patients about 18 hours a day to take care of all of the routine work that they have to do between chronic care and between preventive care. And chronic care is a huge burden. Almost everyone in the United States knows somebody with a chronic health care problem. And lots of those patients have more than one chronic disease, so diabetes and hypertension often come together. And we don't have a great delivery system for healthcare in the United States. We're still very much in silos. Even at Harvard Vanguard and Atrius Health, where we have Epicare, which is an electronic record that's shared throughout all of our groups, we still find silos of care. And then there are the constraints in terms of really using the technology that's available to us. So, what are the things that we have besides electronic medical records? So you have some. On a daily basis, though, sometimes when you're slogging through your work, it's hard to actually take advantage of those. So we need to find ways that we can make those tools available to providers easily. So what is the cost of healthcare, and what actually do we get for our money? So this is a cartoon that I like, and it says, okay, now open your wallet as wide as you can. There really is a perception in the United States that more is better. Yes, I want my MRI, yes, I want my CT scan, is a very common refrain from patients. So how does the spending in the United States compare to other countries across the world? So this is the US right up here at the very top, where we spend 17.7% of our GDP on healthcare. And we don't even really have the best system or the best care. I'll show you that slide in a minute. And this is the health expenditures per capita. So the light blue is actually private, and the dark blue is public. You will notice that the United States does not have much public dollars. So this just is a reflection of the fact that most of our health care is from employer-based health insurance. Anybody read Atul Gawande's piece in the New Yorker in 2009? You should read it. But this is what, so he looked at McAllen, Texas, and the other place that he looked at was El Paso. Yeah, so those two, he looked at the hospital costs, okay? The average income in McAllen is $1,200. They spend more than that on the health care per year in Medicare. And comparing quality metrics on the hospitals between McAllen and El Paso, do you think McAllen did better or worse, or the same as El Paso? What was that? Worse, yes, did much worse. So more is not always better. And this is actually a study from a number of years ago by the World Health Organization that looked at healthcare across many different countries, and the United States was 37th among the countries that they looked at. They don't actually even do this statistic anymore because it was too complicated. So we spend the most, and we don't really get the most for our money. I think that's the message I wanted to send to you. And here's a slide looking at healthcare spending. This is from a while ago, but it looks at healthcare spending between high quality up here and low quality, and you can see that the dollar amount goes up. So low quality, high costs, don't move to Louisiana. I apologize if anybody here is from Louisiana. So what do we do for, as far as paying for quality goes? So in 2004, we started out with pay for performance measures. These were mostly HEDIS measures. I'm sure you guys heard about these from Barbara Rapson this morning. Utilization measures, so how much do you use healthcare services? And then patient satisfaction surveys. And I remember when I was at Tufts Health Plan, we used to send out patient satisfaction surveys on a regular basis. We actually send them out on a rolling basis at Atrius Health. So we are always getting information back on patient satisfaction. I'm sure that Dr. Dodek talked a lot about the AQC this morning. Okay. The alternative quality contract, that basically is paying for quality. And then the new thing, or the new kid on the block a couple of years ago was the ACO, or the Accountable Care Organization. And as I said, you're going to hear from Jean Lindsay tomorrow about Atrius and our participation in what's called a Pioneer ACO. Suffice it to say that at Atrius Health, 50% of our patients are enrolled in some sort of risk-bearing contract, which means that either we get paid more or paid less depending upon our quality measures. And it does work. This is a slide showing that if we're doing public reporting, you get some improvement just by having your numbers out there. But if you're actually getting paid for better numbers, you do a little bit better. So I like to call medicine the next Olympic team sport because I think that medicine in 2013 is way too complicated for this to be an individual sport any longer. This really does take teamwork in terms of working with your fellow physicians. You have to partner with the nurses that are on your team. You have to partner with the LPNs. You have to partner with the medical assistants. And who have I left out of the equation that's important? The patient, exactly. So this is just a little bit of information about the AQC. I think I'm going to rush through it since you guys had this whole lecture this morning. But basically, this was a very innovative program that was developed by Blue Cross Blue Shield that showed that if you get paid more for each gate that you get to, you will actually get better over time. So this is ambulatory quality, and this looks at preventive screening and chronic care management. So it did work. It was a very good model, and it really had the effect that they were looking for. So what about ACOs? I think the interesting thing about ACOs is we have a bunch of different definitions. We have an academic definition, we have a legal definition, and we have a certification definition. So it's a little bit confusing even for those of us who are involved in it on a day-to-day basis. So Pioneer ACO is actually a little bit of a variation on the original Medicare Shared Savings Plan. So what happens in a Pioneer ACO? So this was a program that was put forth by the Center for Medicare and Medicaid Innovation in Washington, D.C. And it is a system whereby we, as a Pioneer ACO, will share in the outcomes if we have good quality, but we also could potentially lose money. And are any of you in the Boston area? So you must be in Boston since you're at Steward. Anybody else from the Boston area? Do you remember a news article probably 2 weeks ago about Pioneer ACOs? The original assessment of Atrius Health's performance was that we actually lost money. I am happy to say, and I'm sure that Dr. Lindsay will clarify this, that we actually didn't lose money. We sort of fell in that gray range, but there is actually a significant potential for losing money in the Pioneer ACO. So basically what happens in the Pioneer ACO is that we have regular Medicare fee-for-service patients that are attributed to Atrius Health through a series of tests. And then the performance that we have on taking care of those patients in terms of quality measures is compared to a similar group of Medicare patients who are not in the ACO. And if we do better than the control group, we share some of those savings, and if we do worse, we're actually at risk for losing some of them. So there are a bunch of benchmarks that we're compared to, and then a bunch of quality metrics that we're compared to as well. So these are the quality measures for the ACO. So there are 33 measures in 4 domains. A lot of these measures were brand new when they came out. There's the patient satisfaction measure, which is very important. Coordinating care of patients, so we put together a lot of care managers in our system to help coordinate the care of the Medicare patients. A lot of preventive health measures, is the patient getting their colonoscopy on an every 10-year basis? Are they getting their pap smears as they should be? Are they getting their screening mammograms? And then also a lot of measures with at-risk populations. And then it's compared to the reference population. So I think it's interesting if you look at the metrics that we're responsible for in quality of care in medicine. So if you look at the AQC, the Pioneer ACO, and the Tufts Medicare Preferred Plan, these are all major risk contracts for Atrius Health. There are 68 measures across these 3 plans. There are 13 chronic disease measures. 3 of them are common to all 3 plans. There are 18 prevention measures, and 2 of them are common to all 3 of these plans. There are 17 medication metrics. None of them are the same through the 3 plans. And there are 9 care coordination, or the patient experience metrics. There's 1 that's common to all 3 plans. And in care coordination, arguably maybe the most important thing in medicine in 2013, there are 0 common measures. So the bottom line is we have 6 measures that are common to the AQC, the Pioneer ACO, and the Tufts Medicare Preferred populations at Atrius Health. I'm glad I'm not the medical director for quality, because Anita Ung, who is the medical director, has to find all of these measures and report on them on a regular basis. So how many of you at your facilities have any training in patient experience, service, things of that nature? Waiting time is a huge patient dissatisfier, I will tell you. Patients feel like we don't value their time as much as they value their time, or as much as we value our own time. So patient waiting is a real thing. It's hard for many of us who were trained many years ago, because we weren't necessarily brought up to believe that medicine is a service industry. But in fact, whether you want to admit it or not, medicine is a service industry in 2013. And that relationship between you and your patient is absolutely key. And it's key not only to the patient satisfaction or patient experience measures, but I will tell you that if you have a good relationship with your patients, you're much more likely to have your patients do what you ask them to do. So if you're asking your patient to take high blood pressure medicine on a regular basis, if you have a good relationship, it's more likely that they'll be compliant with all sorts of care. So the patient-provider relationship is really important, and it's also important to remember that the patient really is the ultimate decision maker as far as their care goes. I don't know if any of you have heard of the term shared decision making, but it's important to get the patient's belief system down, to know what is possible for them in their life at this point in time. And that's an important person to keep on the team. Some healthcare institutions across the United States have actually adopted patient experience type programs from all sorts of industries. The Studer Group is actually mostly centered around medicine. Ritz-Carlton, have you guys heard of Ritz-Carlton? So that's a big organization that has service down pat. They actually have now branched out into training other people from other industries in service. And then, how many of you have been to Walt Disney World? So these sorts of things that the entertainment and hotel industries have had down pat for a while are slowly but surely making their way into the medical environment. At Atrius Health, we actually have been using the Ritz-Carlton program on training our employees. I will tell you that our physicians have been probably the most recalcitrant of all of our trainees during this process, which I think is unfortunate, because physicians really do set the tone, especially in the ambulatory setting where I do all of my work. And they are really the leaders within the local environment. And if you have physicians who are not taking part in delivering good service, it's not as likely that the other people in the group will follow through. So I know that you guys know a lot of this, but our patients don't necessarily get information from the .gov about our performance. I think you heard about consumer reports. Health grades, anybody Googled themselves recently? Even Angie's List. I think I have 3 pages on Google the last time I checked of information specific to me. It's worthwhile Googling yourself throughout your career to find out just what's out there. But this is where our patients are going for information. It's not just couples that are checking each other out online through Google. They're checking you out as well, and they're checking out your hospital as well. So it is very important to pay attention to the way we perform in terms of patient experience. I think the statistics are that if a patient has a good experience, they'll tell 1 person. If they have a bad experience, how many people do you think they tell? 10 on average. Just this week, we had a patient concern. We don't call them complaints anymore. We call them concerns. A woman who was concerned because she wasn't being allowed to have her tubal ligation done by the same physician who had delivered all 5 of her babies. And her threat to the person on the phone from Harvard Vanguard was, if you don't do this for me, I'm leaving, I'm taking my family with me, and I'm taking 5 other family members along with me as well. So it is important. So again, this is the Institute of Medicine definition of quality. And it really looks at the degree to which patients are getting their desired health outcomes and are consistent with professional knowledge, current professional knowledge. So the first thing we really need to do is talk about safety. And I think that this guy probably had it right back in the day. What was his mantra? Oh, thank God somebody remembered the Hippocratic Oath. This is a guy that you don't want to meet in terms of patient safety. Anybody know who this guy is? This is Andrew Loudin of Loudin & Myers, one of the largest plaintiffs' attorneys in the Boston area. I like to say, and this is from the American College of Physicians, that patient safety is really the other side of the quality issue. I do not think that you can have quality health care that's not safe. So I really think of quality, safety, and risk management as 3 parts of a whole. So I do the patient safety and the risk management part, because if we don't manage our risks and we don't keep our patients safe when they're in our institutions or in our offices, there's no way that we can do well in the 3rd sphere here. So have any of you had the distinct pleasure of being involved in any malpractice litigation yet? The problem with malpractice cases is it is just a small, non-representative example of what really goes on a day-to-day basis. So I think you can all probably look at each of these factors that are underneath the surface of the iceberg and come up with a patient scenario in which one of these things was operative. Narrow diagnostic focus gets people into trouble when you are thinking about the differential diagnosis. I mean, we're trained to do this from the get-go. The patient starts to talk, and our wheels start to turn as far as the diagnosis goes. What's the problem that we run into in terms of once the patient starts to talk? So I've seen everything from 9 seconds to 17 seconds is how long it takes for a physician to interrupt a patient once the patient starts to tell their story. If you don't let the patient tell their story entirely, you're liable to miss important things and prematurely narrow your diagnosis and miss the big thing, the elephant that's in the room. One of our major areas of risk at Atrius Healthcare, and I'm sure in other organizations around the country, is a delay or a failure to order the appropriate diagnostic test. So one thing that frequently gets physicians into trouble is they'll have a young patient, maybe a young mother who has recently delivered a child, comes into her primary care doctor with a complaint of rectal bleeding. What would you think of first?
Hemorrhoids.
Right, hemorrhoids. We actually had a patient at Atrius Health with just that story, and nobody had actually asked her family history. She actually had a family history of early colon cancer, and that is what this person ended up with. So you really have to do the right tests, you have to take the right history, you have to listen to your patient if you're going to avoid the tip of that iceberg. It's not always the malpractice suits that really involve the quality of care issues. There are a lot of reasons why patients sue. One is that they are looking for information. That's actually a common thing that you hear about from people who are suing. You know, they just want to know what happened to dad, you know, but nobody will talk to them. So that's one reason that people sue. Some people do sue for quality of care issues, but it's not always those cases where there's a real quality of care issue that end up in a lawsuit. So we also have an electronic reporting system. When I came to Atrius Health, I was really charged with getting people used to the system and really starting to report in the system. This is a system that is made by RL Solutions. It's a common system that is used in the Boston area. It's probably the largest company in terms of error reporting. They have two modules. They have risk management, which is the safety event reporting system. That's what we call it. And then they also have a feedback monitor, which is a place to record complaints or concerns. We do also, we are able to record compliments, and we do get some compliments. But this is our safety reporting system. Now, one of the things I did when I came to Atrius Health was I changed the system and the way it looked for providers and in order to make it a little bit easier. When I got to Atrius, providers had to click through 7 different screens to complete a safety event report. And I learned a long time ago that the more clicks, the more dropout. So we took everything and put it onto one page, and each of the fields, so I know you can't read this, but up here is the who's involved. So we have patient events, we have visitor events, we have employee events, and we have facility events. So as you fill out this form, each drop-down menu, as you move from the top to the bottom, is constrained so that you're not scrolling through long lists. And this had a huge impact in terms of reporting. Anybody know who this guy is? I'm sure you know. So this is Paul Batalden. He is one of the founders of the IHI. And I think he said something which I think is really important to remember, is that every system is perfectly designed to give us the results it gets. So if we're not getting safe care in medicine, it's really primarily a systems issue. It's not so much a person issue. I think many years ago when there was a singular event in Boston, it was a person type of issue in terms of safety. There was the blame game, as I call it. But what we've learned over time is that we really have to practice in a safe system in order to deliver safe care. So I don't know if any of you know who this guy is, but this is Deming, who was a really brilliant guy in terms of manufacturing. He couldn't get anybody in Detroit to listen to him, so he actually went to Japan and went to work for Toyota. And you'll hear, if you start to talk about things like the Toyota system or lean or systems engineering, people or physicians especially will say that patients aren't widgets. And they don't want to have cookbook medicine. I don't think that we are calling patients widgets. I think we just know that we need to move patients through a system. And if we don't have a clear system of how we're going to move patients through care, through an individual, whether it's an individual office visit or whether it's a hospitalization, if we don't have clear steps and we know what needs to take place at each step, we're very likely to miss one of those steps. So I love Atul Gawande. He's a brilliant guy. Does anybody remember this story? So he's actually a surgeon from the Brigham and Women's. He's also on the faculty of the Harvard School of Public Health. But he's just a really brilliant writer. So, whereas if I took a group of my daughter's friends to eat at the Cheesecake Factory, I would deal with the stress of that situation by having an extra glass of wine. But Atul Gawande took it upon himself to actually start to look at what happens in the kitchen at the Cheesecake Factory. How is it that the Cheesecake Factory can deliver all of these meals in one evening and have them all look, smell, and taste the same? And then he compares that to medicine. Why can't we do that in medicine? Why can't we have formula for care that is the right care that is followed throughout the system? Do any of you know the terminology standard work? So standard work is work that you do. It's stepwise. You always do all of the steps. You always do them in the same order. And you always complete everything that's in the standard work. And that's really what the Cheesecake Factory does, is they have standard work for each of the items on their menu. Anybody ever looked at a menu for the Cheesecake Factory? It's huge. It's a book. So it really makes a lot of sense that you would have standard work for each of those things, and that's really their method of quality control. And that's really what I believe we have to move to in medicine. And I know people will call it cookbook medicine, but we, from a distance, can always explain what the right thing to do is, but we don't always complete all of the steps when we're actually in the process. And the reason we don't do it, we're human beings. We're not perfect. So we need this sort of organization around the care that we deliver. So some of the terminology that you'll hear for this sort of thing in medicine is lean engineering, Six Sigma, which refers to a very low error rate. The Toyota production system is another terminology. And then the Virginia Mason production services system is really the Toyota production system that Virginia Mason, which is an organization out in Seattle, has taken and really customized to medicine. One of the things that I did at my last position, which I am very proud of, is that I attended the first Virginia Mason production system seminar for people outside of Virginia Mason in May of 2008, I think. And actually was the first group, North Shore Physicians Group, was the first group to have the Virginia Mason Institute Roadshow come out to Salem, Massachusetts, and really teach the physicians at North Shore Physicians Group what it is to take care of patients in a system of flow. So again, the Institute of Medicine definition, the degree to which health services, again, both individuals and populations, increase the likelihood of the desired health outcomes, so you have to take into account what the patient wants, and that are consistent with current professional knowledge. So it's always going to change. We use the triple aim as our definition of quality at Atrius Health, which talks about the care of populations, experience of care, and I think this is the other thing, is that we have to be good stewards of our healthcare dollars. So some of the things that we've done at Atrius Health are patient-centered medical home. I'm sure all of you are familiar with what a patient-centered medical home. Has anybody had an ambulatory experience in a patient-centered medical home? I think the original definition, which was from the American Academy of Pediatrics, is that this would be to patients a home where they would go for all of their care. So it really is a place where they consider their care to be delivered. And there are services within the patient-centered medical home such that you don't have to necessarily go to a different silo excuse me, for every different ache or pain that you have. As far as the care managers, there are also population health managers that we've started using at Atrius Health. So these are people who may just look at the really healthy patients. You know, there's a lot of care that we're supposed to deliver for healthy patients in terms of preventive care. Population managers who are not RNs and are not LPNs, these are usually people with other degrees, who are trained to reach out to populations of patients and make sure that they're getting the preventive services that we know that are good for patient care. And then I think it's also important to have a good reporting structure so that you know when errors occur in your system, because without knowledge about what's not working, we can't fix it. So one thing that we've done is started talking about practice variation. Has anybody had any practice variation data delivered to them? So this is really looking at information that's delivered to providers that is actionable and non-judgmental, okay? And you have to be respectful, but it's unblinded data. And you're giving people information about how they're performing compared to other reference groups. Most doctors don't want to be at the bottom of the pack, and so using data in a public fashion can be a really powerful tool. This is some data that was generated from Atrius Health. This is on patients who were seen with a chief complaint of chest pain. And this shows the variation in the care that they receive. So we looked at 596 patients. Half of them got some sort of stress test, even though their Framingham risk score was less than 5%. And if they'd had an EKG within the last 2 years, they still got it repeated if they came back in. 5% were done in women under the age of 45. 63% were exercise, but then there's all of these 20% and 18% that are very high cost, even though these are all patients with a Framingham risk score of less than 5%. And 14% of the tests which were ordered are not what would be really the absolute most that you should order in this setting. And this is what happens sometimes when you present physicians with this sort of data. The first stage is, that's not my data. You made a mistake. You have to be very careful that you've got good data, that you've parsed it every which way, and that it is airtight. Once they find out it's airtight, then they're just mad because they just don't like being called out on things. But eventually, they get back to acceptance. And this is the kind of data that we're starting to use for all sorts of things. So stress testing, low back pain, imaging and low back pain is another area. The other area that we're working on now is actually opioid therapy. So I'm sure all of you are aware of the issues around chronic opioid treatment. So we're starting to take data out about prescribing habits. So basically, this is a program where specialty organizations are starting to talk about some of the overuse of medical technology. So I'm not actually familiar with the lists for any particular specialty, but I know that imaging for low back pain is one of those. I believe that routine urinalysis is one for nephrology. That's one of the practice variation programs we worked on at Atrius. It was pretty common for people to get a whole slew of pre-visit labs, regardless of what their past medical history or their problem list was. So we've actually pared that down so that they're really only getting the tests that they need. So again, safe, timely, effective, efficient, equitable, and patient-centered. And hopefully at some point before I check out, we'll be at the top of the mountain.